So suicide, which is a very, very important part of our function as nursing. Um, Before I get into the material, does anyone have any first-hand experience with suicide, whether it relates to clinicals or work or anything?
Only suicide attempts.
Only suicide attempts? Okay. So it is thought that suicide could be a genetic factor. It could be caused by biological issues, psychological issues, or even cultures. So genetic. Sometimes I have patients who tell me my mother attempted suicide, or that my mother attempted suicide, or my mother killed herself, and I've had several suicide attempts over my lifetime. So sometimes it could be a genetic factor where it's those coping mechanisms that one learns. Michael, you mentioned my nephew got into trouble and went through it in jail. Like he was very suicidal while in jail. Oh, he had a successful attempt in jail. I'm sorry to hear that, Michael. Very sorry to hear that. And I must say, we think we know nothing about suicide. We're supposed to be on a watch. And that's the thing, when someone is hell bent on doing it, they have a plan, they have an intention, it is very hard to stop them from doing it. They will find the means. It could be caused by the biological factors, faulty neurotransmissions, usually serotonin, could be hormonal imbalances. And as we speak about these biological factors, these are some of the same factors that play into symptoms such as depression, which is usually precipitant to someone attempting or having those suicidal thoughts. It could be a psychological factor. The patient has a sense of hopelessness. And very often, these patients will tell you, I feel hopeless, like I have nothing to live for. What is the point of continuing with any of this? It could be caused from an isolation from a social group, feelings of abandonment. Maybe it's a teenager who's being ostracized from the other ones in their group because of something that happened, which could lead to isolation or feelings of abandonment. It could be related to a recent loss. They lost someone else in their lives, and as if maybe that person was their protective factor. Now they have nothing else to live for. Very often I'll see that, like with parents and kids. Like, my daughter died, my younger daughter died, and like, why should I go on? She was my whole purpose for living. So there are different factors that will play into it. Suicide is the 10th leading cause of death in the United States. And you probably think, okay, we learn about suicide. It's one of the things we have to learn about. And I just want to implore you of the importance of being aware of patients' intent and plans to commit suicide, because it is very real. I have several patients who have attempted suicide, several patients who attempted suicide over the course of their care. It is the third leading cause of death in ages 15 to 24. There's one suicide every 12 minutes. For every successful suicide, there's an estimated 12 attempts. Highest or higher in the veteran population. When suicide happens, it's not just for the patient, or I'm sorry, not for the patient, the person who has committed suicide, but there is usually a ripple effect for family members, for those in their circle, maybe co-workers. It's usually a huge impact on those around them. More men than women die by suicide. Why do you think so? Yes, they'll act on it, usually more lethal attempts, yes. So while the woman will probably attempt it as well, men are using more legal means, and as a result, they're usually more successful. Actually, more women attempt, but men are a lot more successful. It is stated here that there's a lower incidence in non-Hispanic Blacks, Hispanics, and Asian Pacific Islanders. There's increase in rates in those in the age group 50 to 54 and 80 to 54, 80 to 84 as well. Increase in African American males, Native American Alaskans, and males over 65 in general. Largest increase in white males ages 85 and older. Those aged 65 or more, or women, are likely to have seen their primary care like the year before. And this is why when you see patients, you assess them, you ask them about suicidal ideations. And even if the patient is not coming out and saying, I am suicidal, you want to look for those cues that give you some insight into how the patient is feeling. If the patient is not, even though they're not saying I'm suicidal, they're telling you, I quit my job, I gave away all my worldly possessions, I made sure I updated my will, I'm selling my house. Like, doesn't that sound like they're preparing for something? Or is it the patient that tells you I'm hopeless, there's no reason for me to continue living, I have nothing to live for? So while they're not saying the sign over here, hey, I'm suicidal, we have to make sure appropriate assessments to get information about suicide. So there are some myths surrounding suicide. And one myth is talking about suicide increases the risk. And I see this a lot in my adolescent population, where they'll come in with parents and the parent is like whispering it, or if I say to the child, are you having any suicidal thoughts? You should see the mother is like, oh my goodness, she said the S word. Like, we should be pussyfooting around this subject. No, these are issues that are real, and kids are very aware of the word suicide and what it means, and these are issues we have to attack head on, ask these questions directly. There's another myth that asking about suicide may put the idea into someone's head. Absolutely not. People are less likely to make suicide attempts if they act less depressed. What are your thoughts on that myth?
How do you act less depressed?
You're asking how?
Yeah, is that what you said?
Yes. So people are less likely to make suicide attempts if they act less depressed. And you're asking how could one act less depressed?
Oh, you just mean like seem cheerful around other people even though they are depressed?
Yeah. All of a sudden they started going out of the house. They weren't engaging. Now they're engaging. They seem happy. Like, oh, he must not be depressed anymore. And Kelly puts here, they could be faking it. Absolutely. They could have just made peace with the fact that, hey, this is my sad, depressed life. I'm just going to kill myself and end it. Let me just enjoy the next couple of days because I know it's going to be over soon.
Yeah, you hear stories about people saying it came out of the blue, or I never knew the person was depressed or something like that. So it definitely happens that maybe you can't see those signs of being
Those internal struggles. And you're right. It happens. Like, you think everything was okay. You're like, oh wow, I couldn't imagine that he seemed so okay. So remember, not always as they present. And this is why it's very funny. Like, when I open my conversations with my patients and like, how are things going? Like, hey John, this is Zoe calling for your appointment, or how is everything? Oh, I'm doing great, Zoe, and how are you? I'm doing great also. And I'll be like, so how are your moods? Oh, Zoe, I've been so depressed. So this is why you have to ask those next questions, okay? Suicidal attempts are just a cry for help. That is a myth. If a patient is suicidal, that is what they are, suicidal. And yes, they do need help, but it is not just a cry for help. It is an attempt on their lives. Holidays are times of the highest suicide risk. Suicide risk is heightened from January through December. All year, people are thinking of committing suicidal acts. So it's not just around the holidays. While you'll have an increase in depressive symptoms, or like I have patients already telling me, I'm feeling okay, but I know I'm not going to be feeling so good in the next couple of weeks because it's about to be the holidays. My mother died. I don't have family. I don't have anybody. I don't have anybody to go visit. And by default, the holidays is a period where they struggle. But it's not just the holidays. You have someone who will tell me in the middle of July, it's the month that I struggle with. This is when I lost my child, or this is when I was late. You'll have someone in January tell me, oh, this is when I experienced my trauma. So it is always a heightened time for suicide, not just like we should put on our flashers around the holidays. It happens throughout the year. All suicide methods are equally lethal. I don't think we need to explain it any further. That is definitely a myth. If someone tells you I'm going to kill myself by eating a box of crayons, or they tell you I'm going to go home and put a gun to my head, those are two different, while they're both suicide attempts, the level of lethality varies greatly between the two. Suicide is contagious. I mean, it's a myth, but in the current climate, it's hard to think that it's not contagious. Having worked in a school setting myself and teenage girls, it's like what everybody does, it's what they all talk about. Is it contagious, or is it faulty coping that our teens are learning? Only people with a well-developed plan are likely to attempt suicide. What do you think about that?
Isn't it true that a lot of suicide is impulsive, like very impulsive?
Well, I can't speak to say if it's usually more to impulse than planned, but I can definitely say you are correct in saying oftentimes it happens in an impulse fashion, because they could just be feeling this way. Oh, let me just kill myself, and boom. Because sometimes they don't even know that their supposed attempt at times would be their last and final attempt. Like I had one patient who she came in one day and she was very, very sad, and she's like, did you hear the news? I'm like, I really don't watch TV. And that's true, I don't watch television. I just don't have time to watch TV. And she's like, my niece committed suicide the other day. I'm like, oh wow, I'm so sorry to hear that. Can you tell me what happened? And she shared with me that her niece had a long history of mental health issues, a long, long history of mental health issues since, and this niece was probably 19, 20, I want to say. So since like her early teen years, in one facility, out the next, in, out the next. So for some patients, for some parents, it gets old. Like this is little Susie, always who's always depressed, who's always cutting, is always suicidal, and they go through the motions. She goes in one institution, she comes out, she's doing fine. She goes in, she comes out. So it becomes a norm. And this time in particular, she was in inpatients, and she called her mom, oh, I'm sick of the tired of being here. Come and get me out of here. I don't want to be here anymore. And mom went and picked her up. This was probably what, the 100th time she was in the hospital, and the 100th time she was going to come home. And mom picked her up, and they were on their way home. They got into some little spat in the car, and she grabbed the wheel into a pole, and she died. And her mother is struggling with such guilt, like to say, what if I hadn't picked her up? What if I had not gone and taken her out of the hospital? But who knows? Had it not been that time, it probably would have been another time, because she has made several attempts. So very often they make these attempts. I'm sure they don't know which one's going to be their final, and that's why we have to take every single report off or attempt off pretty seriously. One myth: if someone wants to die, we have no ethical right to intervene. So remember, if someone is a risk of harm, not just to others, but to themselves, we have a duty to protect. We have a duty to keep them safe. If someone says they're going to kill myself, well, we want our patients to be autonomous. No, we will not sit back and allow someone to attempt suicide, or even worse, become successful in doing so. So what are some nursing interventions we could do to keep patients safe who say they're suicidal?
Place them on a watch.
Yes. Eyes on. One-to-one. Therapeutic communications to see how much you can get them to open up. Remove any means. This is not the patient you're going to have with belts in their room or shoelaces. So these are all good answers, and these are things, while the patient is probably going to be very upset, how dare you take my belt, I have no shoelaces for my shoes, it is in their best interest, because what if you don't make those little adjustments and that patient carries out that act? What if? So what are some suicidal behaviors? We can see the patient who has suicidal ideation. This is a patient who has thoughts. They're thinking about suicide. Suicidal threats, right out. They will tell you, I'm going to kill myself.
Anxiousness.
Anxiousness could be something that feeds into the attempts and the behaviors. Yes. I see excessive risk taking. Yes. This is the patient who tells me, no, I'm not suicidal, but I will go to the Berlin Turnpike and I race down the Berlin Turnpike late at night with my friends. I'm like, that's dangerous. What if you die? Huh? Then it's my time. Mistaken behaviors. Giving away personal items, those things, little Johnny loved that soccer ball, and he told you should give it to his cousin, and he's also been struggling with some issues at school with others. Like, those are little cues you look for, okay? Suicidal gestures. So these are activities they will do to lead others to believe that they have just made a suicide attempt in order to communicate their distress. So this could be cutting or taking pills, asking for help, showing you, hey, I'm very distressed over here. I need someone to pay attention to me. They could have a plan. And this is why when patients say I'm suicidal, you want to know, do you have a plan? Do you have intentions to? And the plans could be very varied, and when you listen to them, sometimes you're like, nah, you won't be able to carry that out. Or it could be as simple as, I'm going to overdose on my pills, the same pills I'm prescribing, the same pills you're telling them to go home and take when they have a 30-day supply. So these are the things we listen for. Like sometimes, well, very often if I have patients who tell me they're going to take pills, I would immediately tell them, you're going to start getting your meds bubble packed, or even better yet, I'm going to order a nurse to come by and administer your meds. Has this patient had suicidal attempts before? What is the likelihood that this patient will try it again? I mean, they already show you they have the balls to try it once or twice before, so you should probably be like, hey, I know he's not joking. And of course, there are some patients who are indeed successful in suicide. So risk factors for suicide: belonging to a high-risk cohort, so such as those with mental health, substance use, history of previous attempts. They have psychological symptoms such as depression, serious mental illness. If their plans are lethal. I have one patient told me one day, when I get out of this appointment, I'm going to walk out into the street and get hit by a car. Of course, I couldn't allow that patient to just walk out of my office. That patient was sent to the hospital for further evaluation. Whether she was serious or not, she told me she was suicidal. That was her plan, and she told me she had intentions to. If the patient has had recent losses, usually heightens their risk at that time. Medical illnesses, financial issues, yes. Legal issues, limited social supports or resources, stressors in the family. They have no one to talk about their problems with. They feel like they're alone. Then why not just kill myself? There's no one for me to reach out to, no one for me to talk to. So That's some way the way they take out. They have poor coping skills. I get angry or I get depressed. Let me kill myself instead of using A, B, C, or D as other coping skills. So this is why it's important for us to help patients to develop coping skills and educate them on how to employ them when they are in distress. And very often they'll be so distressed that they can't even reason through using those coping skills, but it is good for them to have them. So at least if they're in an acute care setting or something like that, we can encourage them to use them. What are some warning signs of suicidal behavior? Often hopelessness, which is often the most important sign. They will share their sense of hopelessness, withdrawal, not talking, not reaching out. You've been calling them for weeks and not returning calls. Often preoccupied with death and dying, talking about what kind of funeral they would like, what life would be after death. Do they believe in afterlife? How would you feel if they weren't around anymore? They could also feel as if whatever issue, say they got charged for a crime, whatever issue they're facing right now, it's unsolvable. It's out of their control. I can never get through this. This is just too much for me. It's gonna end me. And they choose to end themselves before they even work on trying to find a resolve for the problem at hand. Or they can't see a future without pain and suffering. Have they lost someone? Often suicide is determined when they can see no alternative to relieving their pain or suffering besides suicide. As someone mentioned, those risk-taking, self-destructive behaviors. Is this patient drinking themselves sick every day, using drugs, like engaging in those risk-taking suicide behaviors where you could just die? And as we discussed prior, the sudden elevated mood, making those final arrangements, or giving those hints. So I want to make sure we share with our patients. Anytime I talk to a patient who's suicidal, I try to get a plan. I try to, one, have them contract for safety. I need for them to tell me that I will not attempt suicide while I'm having those thoughts right now. I have no plan, I have no intention, but I still provide them with a suicide prevention line. I get them in touch with crisis, and we have those discussions. And the suicide prevention line number is presented there for you. Your nursing diagnosis could range around risk for suicide, risk for self-directed violence, ineffective coping, hopelessness, powerlessness, worthlessness, disturbed thought process, poor self-esteem. Those are some of the issues that usually feed into this person not feeling that they're worth anything. As you assess patients for suicide, remember we spoke about some assessment skills before. So if you want to look back into your older notes, you're going to look at their behaviors, their history, and it's stated, use the word suicide. Don't be afraid to say suicide, or you're having thoughts of killing yourself. Some patients get offended when you ask, what would I look like, a dummy? Why would I kill myself? But this is a question I ask everyone. This is what I tell them, because very often they think you're targeting them to ask them about these suicidal questions. Usually they have those feelings surrounding a suicide, or if not suicide, it could be like drug use. I'm like, these are standard questions I ask everyone. Get information from others. Maybe this patient is majorly depressed and not talking so much. Reach out to family members, friends, like who is their contact person? See how they've been over the past couple of weeks. Do they have an history of ideations? Do they have a history of saying, I'm gonna kill myself? Like, you wanna see how this person usually copes. History of threats, history of gestures, a history of partaking in risk-taking, self-destructive behaviors. You wanna know how this person functions usually so you can have a good idea of their level of possibility. Do your mental status exam, examination, and remember safety, safety, safety. Now, as we all assess for suicide, we talk about suicide. I guess it never happens until it does. Usually when I teach this class, I'm a mother of many children. I'm a mother of 7.